Hello there.
Hey,
You're always in your car.
my daughter gets off of work at 6 usually.
Gotcha.
So I'm just waiting for her to finish up. And yeah, I know it's like I got to join half of both of them in my car. So I
No
start off
worries.
at home and then I finish at home.
No
Yeah.
worries at all. It's hard to schedule these like online classes for Zoom because like we can't really do it Monday through Thursday because so many people take other classes and
It's a good
um
time to do it generally. But, when you have teenagers, there's just a lot of stuff. So,
well, thankfully I'm never gonna have to know what having a teenager's like because my kids are stuck at their ages and they're just gonna be 8 and 5 the rest of their life.
they will. They will.
Mhm. Yeah. My
Yep.
daughter is 8. She's 99.99th percentile for height. And so,
Wow.
um, and I'm 5'9" with cowboy boots on. And my wife is 5'9" with flip-flops. And so yeah, she is almost, I mean, like she's almost as tall as we are.
That's so funny.
Mm-hmm.
That's hard for kids that are really tall like that because people expect them to behave more maturely than their age.
Yeah. Yeah.
My daughter was tall as well, and she's a year and a half younger than my son.
Hmm.
And so, an additional component for us that was challenging was people would always say in front of him, I can't believe she's the younger one. And it was just like, dude, are you even thinking at all what you're saying to this boy?
Yeah.
So he got taller than her, and she actually kind of leveled off about, I don't know, like maybe sixth or seventh grade. And she's like 5'7". So
Huh.
but she was taller than her teacher in first grade. So it was really interesting.
Wow.
Mm-hmm.
My
Yeah.
son is very short. He's like always been the shortest. Everyone towers over him. So I don't know what's going to happen with that.
Hmm.
But
Yeah, I was probably supposed to be taller than what I am. But uh, I had really severe asthma growing up, and I had a steroid inhaler that nobody really taught me how to use. I just used it every time like I thought I needed it. And then on top of that, I remember I was talking to my wife about this the other day. I my my dad started making me lift weights when I was about 8 years old,
oh,
and so which is not great for growing
My
tall.
goodness.
Yep. And so that combined with the with the steroids um, didn't help. Um, just a different world back then.
Mm-hmm.
Well, we will get going. I'm going to share my screen. Let's see if I can get the right one pulled up here. Because actually, I want to talk. Yeah, so tonight we will talk about trauma. And if y'all were just in my last class, it'll be, I would say, pretty pretty different perspective as it looks at adulthood. But also, I do want to talk about um, like the somatic symptom disorders and sleep disorders. I definitely want to get into those tonight because this coming Sunday, I want to talk about dementia and personality disorders for sure. Sound good to everybody?
yeah. Can you just
Yeah.
tell me just what the topic was last week? Because I didn't hear any
Um,
of it. So I don't know what we talked about.
Gotcha. That was the anxiety disorders.
Okay.
Mm-hmm.
Okay.
Yeah.
Thanks.
And I will get that stuff posted for y'all. It's kind of been a busy week. Let's see. Share my screen. There we go.
Dr. Armstrong, I was going to say one comment that I didn't get to share in the last class, but when you were
Uh-huh.
talking about PTSD and sleep disorder, how
Mhm.
sometimes people will think it's the same. I'm not sure if you said this, but I have experienced, I can see why they think that, because I've experienced how when someone who has PTSD, they have got to have sleep. When they don't sleep, it just, their brain can't get well.
Yeah.
And so I can see how they get confused and think it's, well, the sleep makes it better, but you can tell it's something different, but it just is really the thing I've observed. And my brother had
Mhm.
PTSD, and he had to sleep when he got into that state.
Yeah.
Yeah.
And in fact, there's like a rebound, like catatonia almost, that is described by a lot of people, where after experiencing a very emotional event or like a traumatic event, there's like a come down where their body and their brain feels like it's being tugged at by a rope, like towards the ground even. And personally, I believe that it's a survival kind of mechanism that the brain, I mean, it's literally trying to get that person to go to sleep, because it's like, okay, that's the limit. We're not going to be able to hold anything else the rest of the day. So let's just draw the line there. So let's talk about a little bit more on the HPA axis and sleep, and how that all relates to trauma. What I didn't talk about last class, or last the child and adolescent same lecture here, is that we've got two different memory systems in our brain, and we've got an implicit memory system that essentially the record button has been on ever since that, basically the last part of the first trimester. Okay. And then you've got the explicit memory system, and not explicit like as in like bad language, explicit as in these are the memories that you're able to consciously recall. And if you think about this just for a second, I want you to think about, what's the earliest memory that you have? And in most cases, in fact, I've never met anybody who has a memory before their language started to come on board in their brain. In other words, around between like a year and a half to 3 years old, some people might have a few memories there, but they only have those memories as it relates to the onset of their language acquisition. Those functions started to come online. And so explicit memories don't exist until language is on board. But that doesn't mean that the implicit memory system hasn't been on record even before you were born. In fact, there's a book, Brain Rules. There's the kid version, or the parent version of that's the Brain Rules for Babies. By, his last name is Medina, and he's a neuroscientist out of, I think, Portland. But it's really great. But it talks a lot about how, with the brain having that record button always on, how that relates ultimately to like long-term relationships and our perception on life in general. But bottom line is that our implicit memory system starts even while in utero, and there's pretty considerable evidence now to suggest that even while in utero, mom's fluctuations, or the presence of stress hormones from her own psychological or physical stress, can influence or start to influence the implicit memory system of that baby. There's actually where that comes from is the research on, I think there's some hospital up in Canada that they looked at the long-term psychiatric outcomes of kids or babies that were born during a weekend where they had a really severe snowstorm causing like disruption to like everything. And then they also they compared that to the kids that were born like a week or two later, long term, whenever they didn't have that snowstorm, and as that related to like the mother's cortisol levels. And so they found that the moms who were having babies during the middle of that snowstorm, I mean, rightfully so, their cortisol levels were a lot higher, right? What they looked at then was, I think, 5 and 10 years out, and the odds of there being any psychiatric diagnosis in the kiddos that were born by moms with higher cortisol levels. And there was an association, and it was pretty strong, meaning that although the correlation doesn't mean causation, there is a pretty clear association with being exposed to stress hormones while in utero and the later development of psychiatric illness. And it's not just psychiatric illness, but you got to understand psychiatric illness predominantly comes from exposure to stress. Now, there's always a genetic component, but you need to know that, like, whether it's depression or anxiety or PTSD, whatever the diagnosis, even dementia for that matter, the longer you are exposed or you experience chronic stress, physically, your body eventually starts shutting down, right? But from a mental health standpoint, psychologically, you start to experience a wide range of symptoms. And I'm saying all that because as it relates to PTSD or trauma, is we like to have trauma like circumscribed out from the rest of the diagnoses, like PTSD separate from everything else, or depression. But can anybody tell me what are some similar symptoms in depression that you might see in an adult with PTSD?
Social isolation.
Mm-hmm. Absolutely. Social withdrawal. Anything else?
Yeah, like all that, like attention, memory, executive functioning.
Yep. Irritability.
Yeah.
Low mood. Right?
Yep.
But those diagnoses are located in way different parts of that book, though, which is supposed to be designed so that the more similar like a diagnosis is, they're supposed to be real close to each other, right? And so it implies a level of distinction there that clearly, like, just if just by logic alone, tells us that maybe it's the same part of the brain related to both. The truth is, the reason why there's overlap between all of these different diagnoses is because it's the stress system in the brain that's the most affected by all psychiatric illness. And so you get overlap between generalized anxiety disorder and major depressive disorder and bipolar disorder and schizophrenia and ADHD and PTSD and OCD and substance use disorders. You get overlap there primarily because we're talking about a spectrum of stress responses, basically.
Is the paranoia and the delusion that you see in PTSD also associated with that anxiety response? Same kind of brain mechanism?
It's the same. It's the same. It's absolutely the same thing. It's the same thing why you'll see people who have social anxiety. When the more stress that they have, or the more chronic and severe it is, it ramps up from being anxious socially to like hypersensitive and even paranoid.
Mhm.
So paranoia is not like an on-off kind of like a definition. Paranoia is a spectrum. You can be on the far end where you don't trust anything or even yourself or anybody, to the other side where you might be skeptical, right? But why in the world would our brain want anybody to ever develop paranoia?
Because they're in, I think their amygdalas, I think they're in fight. I
Mhm.
think they're trying to protect themselves.
I'm telling you right now, I sure hope if I ever, I mean, not that I hope I get arrested, but if I ever got arrested and had to go to like prison, I'm hoping that my brain develops some paranoia while I'm in prison. Because if not, I probably won't live very long. You have to understand that the brain is wired and it primarily cares about your survival. And as it relates to trauma and stress, the longer we experience stress, like the bad kind, distress is what that's called. The longer we experience that, the longer we, or I would say the more our brain begins to associate that with what it should be like, biologically speaking. All right. So that you hear a lot about the HPA axis. That's the hypothalamic pituitary adrenal axis. And really, I wish it would be the AHPA axis, because it kind of begins with the amygdala. And if you wanted to go further, maybe the P lowercase f a HPA axis, the prefrontal lobe, amygdala, hypothalamic pituitary adrenal axis. But let me ask you this. So like why do we have the HPA axis? Like why do we even have a stress response? What's the purpose of that?
I think it's to protect ourselves,
Yeah.
to get us on alert that we need to get ourselves safe.
Mm-hmm. And the good news is, by the way, you can look this up. You're gonna think I'm making this up, but it's not. It's the truth. It's like the one thing I remember from grad school biopsych was you have built into your brain the superior and inferior colliculi, which are little tiny nuclei in the brain. The superior nuclei deals with incoming like things that you see, and it's almost like a reflex loop that, you know, like if you've ever been like walking outside and it was dark or something, and you thought you saw like something from, you know, out of the corner of your eye, and it made you jump. That's because your superior colliculi at some point along the way has learned to tell the amygdala, hey, it's happening. I told you. Finally, you know, there's a wild animal coming to get you, right? The inferior colliculi deals with sound. So if you've ever been startled by like a loud noise, or especially like with lightning, stuff like that, you don't have to think about like, oh, that was loud, I'm going to be triggered now. Sorry, Y'all can probably hear my kids in the background. But
Okay.
you don't have to think about that, because those parts of the brain have direct connections with your amygdala, and they're like best buddies in your brain. And so you have this reflex that occurs that turns on that HPA axis, or the stress response, which then pumps blood to all your muscles, dilates your pupils, increases your heart rate and your breathing rate, getting you ready to fight or flight. After you realize that it was just a pine cone and that it wasn't really a wild animal out to attack you, your brain says, actually your frontal lobe says, all right, that's enough, you two. It's not that big a deal, it's just a pine cone. Which then, from that HPA axis, slows it all back down, and actually uses endorphins, by the way, as a part of that process. Which is an interesting thing, and might explain why some people are drawn to like watching scary movies, things like that, because of a higher endorphin response to it all. Anyway, endorphin is the pain-killing, what they call an endogenous opioid. So when you take pain medication, like the bad, I say the bad kind, but the potent kind, the ones from opiates, morphine derivatives, that's what endorphins are. All right, they use those to calm you back down, and thankfully, the next night you can go on a walk again without being revved up, because your brain learned, hey, I don't really need to be all that worried, because if I see anything, it's more likely going to be a pine cone than it's going to be like a wild animal. I keep saying the pine cone thing. I'll just tell you a really funny story. When I worked in Colorado, we had mountain lions. And I was terrified that I was going to get eaten by a mountain lion. I worked at a camp way up in the mountains. I had to walk down this long dirt road at night by myself on the side of a mountain. I remember walking down and I was just terrified. And all of a sudden I just heard like this rustling in the bushes above me up the hill. And it just kept getting louder. And so I took off sprinting. And I was like, I know this is it. Mountain lion's going to eat me. And then finally, like, I turned around and looked up there, and it was just like a little, like 20 or 30 little pine cones that had just rolled down the hill. But they were rolling and going through like the brush or whatever, not the brush, but they were going through like on the ground. And so I could hear that, and it sounded like an animal was running, but it was just the pine cones the whole time. Yeah. Thankfully, I was able to sleep that night because my frontal lobe just was able to talk myself down. Now, I'll say this is the difference between that and what happens with trauma is that experience and that is traumatic for that person produces such a significant stress response that biologically overrides that person's ability to shut it down from a prefrontal lobe standpoint. And as a result of that, the body stays on the fight or flight mode too long, and it begins to learn that is what's required in order to survive, and not just as it relates to the trigger associated with that trauma, but also as it relates to stimuli that are associated and even can become loosely associated with that trauma.
That makes a lot of sense.
And so it's a conditioned, learned response, because when I say conditioned, and this is an important piece of this, is that when you experience something that's traumatic, it is natural for you to want to avoid that situation or experience again, so much so that your brain might have too powerful of a avoidance response that prevents you, or you aren't able to process the memory of that trauma or anything like that the way it should be processed. And we'll get there in a minute, but you're not able to do those things because it gets shut down. Your anxiety levels up here, you get rewarded whenever you avoid even thinking about it, and it causes your anxiety to go down by just avoiding it. And that going down of anxiety is rewarding, which then that is what's called negative reinforcement, by the way. Negative reinforcement is the second most powerful type of learning there is. The most powerful is positive reinforcement. And when that occurs enough, you've got two powerful things occurring. One is you're feeling better subjectively, less stressed, by gaining some sort of like cognitive control over it. And then on the other hand, biologically, you're getting rewarded by having endorphins flood the system and dopamine telling your brain, hey, you need to remember this is how to feel better whenever you start feeling stressed. So because it learns that, the next step from there is for your brain to continue looking for new ways for it to feel better all the time. And so it goes from having like a very, circumscribed stimuli that I try to avoid talking about or thinking about, to anything that's kind of associated with it, any thought, or event or activity or memory. And then it starts to broaden even further. And it becomes a reinforced like pattern that the whole thing together ramps up your nervous system so much so that it ultimately prevents your brain from processing those memories, processing those emotions during sleep, by the way, and subsequently being able to gain access back to that frontal lobe and its ability to regulate that fight or flight response. Now, that's an oversimplification of how we get to PTSD, but the truth is that before we get to that diagnosis, you need to know that there's a predisposition or a preeminent risk for developing PTSD. And what I mentioned in last class is we know that really those first 4 years of life kind of set the stage of how much are we at risk for developing not just PTSD, but any of the anxiety disorders, things like that. And that's because our brain during that time in early childhood, it is learning its own thermostat. It's learning what should we be prepared for the rest of our life. So if you've got like a neglectful or abusive parent or caretaker, it's teaching that brain, hey, the rest of life is going to be about survival for sure. We're not going to be able to take a break. So we need to stay ramped up. When that occurs, and it's not that there's no hope after age 4, it's just that if that stage is set, even if we have like a perfect childhood from there on out, and we're 50 years old, we are going to be more at risk at 50 of developing PTSD as a response to a traumatic event because of that than our peers who'd never had that early childhood adversity. And that's because the brain will remember for the long term. I'm telling you, after it forgets every word in the dictionary or everything that you've ever memorized, After it forgets all that, you better believe that your brain is still going to remember what those first few years of life were like. And it's not going to be explicit memory. It's going to be the implicit memory. This is also why we get panic attacks, by the way. If you ever, when you read about panic attacks and panic disorder, and people have panic attacks, to be honest with you, they're not, it's not that they don't, I'll say this. Panic symptoms occur also in PTSD, by the way. And a lot of times it's hard to differentiate between the two. And really, we're trying to differentiate something there that doesn't, like, who cares? Because the treatment is going to be the same. Panic disorder is a acute fight or flight stress response. And a lot of times those folks will tell you, I was just driving down the road and out of nowhere, I started feeling panicky, like I was going to die and I couldn't breathe. And I just kept getting revved up, and I had like this imminent fear of death that was going to happen. And they don't recognize what the stimuli was that triggered them, not because there wasn't one, only because their explicit memory system didn't recognize it, but their implicit memory did. And actually what results in those cases a lot of times is the same thing that happens with PTSD, by the way, is you get, because the brain doesn't have any one thing to latch onto in panic disorder, for example, it starts to just kind of guess at what maybe the trigger was, not even on a conscious level, but it starts to associate, well, I was driving and telephone poles, maybe it was telephone poles, and so from there, as it relates to PTSD, the difference being is that with PTSD, even if that person doesn't talk about the trauma like immediately, the brain tends to go towards associating further and further a lot quicker, in the same way like panic disorder does whenever they don't recognize the stimulus that caused it. All right. There's two ways to look at PTSD for adults. One is PTSD might primarily be, or the majority of it might be, a sleep disorder. And two, with PTSD, it's not a disorder of remembering, it's not a disorder of forgetting, although that might be a complaint of people of memory problems. It's a disorder of forgetting. Specifically, I'll talk about the memory piece real quick first. Your amygdala and your hippocampus work hand in hand. Your amygdala takes all incoming experiences and ranks it and says, okay, well, this is like a 7 out of 10 for survival. Yesterday, what you had for lunch, last year, that's like a 1 out of 10. And then it organizes and prioritizes all that stuff and hands it all to the hippocampus and says, all right, this is what's important. This is what's not. And so your hippocampus just says, okay, all right, well, it sounds like, last year, what you had for breakfast, not that important. So we can forget that. So just lets that memory go. Or it says, yesterday's, that car that almost pulled out in front of you, that's pretty important, because that seems like a dangerous intersection. So we're going to remember that. And so it gets stored for long-term recall in a more conscious manner. Both got stored, by the way, for implicit recall. That's the difference here. But explicit recall, the amygdala, the hippocampus over there on the left hemisphere, is letting some of that stuff go depending on how important it was to the amygdala. trauma, therefore, cannot be concretely defined or in an umbrella way or in a generalized way for the whole population, because that's going to depend on subjective experience. As I mentioned it last class, but I watched The Shining as a kiddo when I probably shouldn't have, and I still have recurring nightmare about that movie, and it's a trauma response. And so we've got an explicit system that is subjectively defined because everybody's amygdala is different, and what determines how our amygdala is, how sensitive it is those first few years of life. Okay. Now, the one thing we didn't talk about last class, and I want to mention for this one, is the idea of there being a complex PTSD, or like if you have repeated exposure to traumatic events, and how that is different maybe than one major event that you experienced that was traumatic. And where the research is on that, and you hear a lot of people talking about complex PTSD, and that needs to be a separate diagnosis. And although it might be an important distinction to make, there's no neuroscience of which I'm aware that suggests that it's a different process or a different pathophysiology that in the brain that produces complex PTSD as compared to just PTSD. What we're defining here is a spectrum, where complex PTSD is probably the more severe form of the spectrum of PTSD as it relates just to trauma and related disorders. But complex PTSD is primarily where your body remains on high alert across multiple contexts, because your brain has associated so many different stimuli, some of which you're aware, some of which you're not, with threat. And so there's no avoidance of stimuli that might be related to the trauma and triggering, because it's kind of always there. That's complex PTSD. But what I would say is there's a lot of that's complex PTSD has kind of become almost a fad diagnosis right now, where you hear a lot of people saying, I've been diagnosed with complex PTSD. And not that I want to ever dismiss anybody like that, but what I want to highlight is two things. One is it's not that we need to say that it's extra PTSD, because PTSD is enough, in my opinion, to define it. But I also want to highlight the importance of why people need or want that unique, complex part of that diagnosis is mainly because it needs to be understood that there's a difference in the severity level, and we need to make sure we're affirming people who've had trauma that what they've been through is traumatic. And so I really feel like a lot of times we have minimized trauma in some ways in our culture. And I say our culture, but culturally, there's been a lot of, even the past 4 years, there's been a lot of minimization of what is and what isn't traumatic, and trying to define what's normal for one generation versus other generations and so forth. But the reality is that when we are working with patients with trauma, which is going to be everybody, we need to recognize and affirm that what they've gone through is traumatic, and that the result of that traumatic experience produced a long-term fight or flight memory system to be on high alert. And that gives us hope, though, because it means that, one, if we can to the greatest extent possible avoid ongoing trauma or repeated trauma, then that will help get our brain back to baseline. Two, if we can get our brain to actually, get the amygdala and the hippocampus to actually work together, and for the amygdala to relearn how to rank incoming experiences better, more accurately, it'll allow the hippocampus to process all of it, which in turn allows the limbic lobe to process it all, such that we can forget aspects of what a traumatic event was, not like details. I'm talking about forget in a biological sense. Forget parts of that so that our brain isn't constantly focused on our survival. That's what therapy does. I talked about it may have talked about it. Yeah, we did talk about it last class. EMDR is a type of therapy for trauma. It stands for eye movement desensitization and reprocessing. I remember not when it first came out, but one of the founders of EMDR was associated with my grad school up in Colorado at the time. And they had trainings all the time. And I remember thinking, I was like, man, this is like hocus pocus. They had like little lights going across the thing. And they had like little paddles that were like, vibrating in people's hands, and they were tapping their shoulders and stuff. And first of all, because I'm a little bit of a cynic, so my first response is always like, that's just snake oil. That's always my response. But I will say this, is that thankfully they continued implementing and researching EMDR, and who cares what I thought or think sometimes. And as it turns out, EMDR is probably the most effective treatment for PTSD and trauma. And what EMDR is, it's a combination of rapid eye movement sleep or bilateral hemisphere stimulation. So what's supposed to happen when your eyes are going back and forth, like when you're asleep in REM sleep. But as it is with EMDR, doesn't matter if it's your eyes or just sensory input, if you have like this alternating input. And combine that with systematic desensitization that's a little bit more gradual, you have really positive long-term outcomes from the treatment of trauma.
Dr. Armstrong, have you heard anything about accelerated resolution therapy, ART? It's kind of similar. I was just curious if you knew anything about it. I was just curious about your opinion, is all really.
I have not.
Okay.
Do you know much about it?
Not that much. I've just heard of it, and I've heard many people saying that therapists saying that they like it with helping with trauma and with PTSD. So I think it has some similarities in that there's still this eye movement part. But I think with, I don't know. I can't speak enough about it. I was really maybe just something to look into. I've heard good things about it.
Sure. Well, I will say this, is that I've had to kind of fight against my cynicism, because on the one hand, I want us to progress in our theories and to constantly find better and better approaches or refine those. On the other hand, sometimes it feels like there's these little split offs from like a good theory, simply almost in the same way big pharma takes the same medication and just repackages it. Just to kind of like, okay, well, they were first to go there, so let's just tweak it a little bit and make it our own, and we can sell it, for $1 million. But here's the thing. A lot of those types of therapies, and like even ERP, gosh, what is that? Something response prevention. I always forget what the E stands for. It's a type of CBT.
Exposure and response.
Yep, exposure and response prevention. Those probably all have the same level of efficacy, if not greater, especially as it starts to really hone in on the giving or the empowering of cognitive control to that client over their own trauma, over their own thoughts, and subsequently their emotions. By the way, they've looked at EMDR, and this is what bugs me. There's a better response to EMDR when that person has one of those light bars versus when it's like the paddles, and versus when people are just doing like the back and forth with their finger. And the theory on that is simply because the belief that this little gadget thing that you're looking at with the light going back and forth is going to help. So there's in part some of the placebo effect going on. But here's the thing. There's also placebo with brain surgery, by the way. People who literally, and it's the truth, people who believe in the technique that's being done on them, even if it's surgery, will always have better outcomes. Yeah. So it's okay, even if the little light thing going back and forth, technically does the same thing as using my fingers going back and forth. I'm all in support of whatever is the most effective. That's like, who cares what's causing it? It's effective. And I'll tell you anecdotally, I believe in EMDR. I don't believe in all the stuff that EMDR people say that it does, but I believe in it personally because it worked for me. And I've literally, when I was in grad school, I spent a year doing talk therapy with a client. And then one of my friends had got the training on EMDR, and I like refused. So I was like, I'm not doing that snake oil stuff. And finally, my client asked me about it, and I was like, yeah, I mean, we can try that. And so we kind of did like a collaborative thing where I was doing talk therapy, and my client had like 3 sessions of EMDR, and they made it further in those 3 sessions than they did in a whole year of therapy with me. And so there is something to it. There absolutely is. And so I'm trying to tell you, don't be as cynical as I am, but be healthily skeptical and try to see what's the core theory being taught here, because a lot of times you don't need to always buy the expensive gear and all that kind of stuff, and you might already know more than what you realize about that theory when you find out it's really just CBT a lot of times. All right, got just a few more minutes left, and a couple of things that I want to highlight just to make it important to note is the treatment of let me get back to, there we go. The treatment of PTSD, especially as it relates to the medications and kind of the future for adults. One, we know that chronic stress, which is PTSD, by the way, increases one's risk for dementia or developing dementia in later life. Doesn't mean that if you have PTSD, you're going to have dementia, but we know that the longer the brain is stressed, the more likely you will develop the pathophysiology of dementia when you get older. In fact, some would suggest that because PTSD affects sleep, and sleep, I mean, I'm telling you, it is the foundation for your physical and psychological functioning. Because it affects sleep so much, that in turn produces a cascade of pathophysiology that interferes with your heart, your cardiovascular repair, your muscle and bone repair, and your brain repair and immune system. And so it does kind of tie back to sleep, but you can't treat just the sleep because you can't get them to sleep. You can't get them to stay asleep when they have trauma. That's the problem. Their sympathetic nervous system has them too revved up. And even if they fall asleep, their brain immediately almost tries to like re-experience that dream process the trauma through a dream, which then in turn activates their sympathetic response and wakes them up out of that state. So they're not able to stay there long enough for the brain to actually do its job. And then over time, that person begins to generalize, like subjectively, and even like maybe even unconsciously, they become conditioned with the fact that every time I look at my bedroom, my brain starts to anticipate that I'm going to re-experience that trauma there. But what we know is when we treat their ability to stay asleep when they have trauma, they are more likely their symptoms are more likely to be diminished and or to go away, depending on the level of severity. And the medications used frequently are actually beta blockers, the heart blood pressure medication. And that's the word I was looking for earlier, is prazosin. Yeah, prazosin, which is a beta blocker, similar to propranolol. That's another one. They'll give that at night. It allows them it gives them a better night's sleep, or increases their odds of their sympathetic nervous system not breaking through. And I'm telling you, it's not just feeling rested, although that's a part of it. It's allowing the brain to process those memories, which in turn allows the frontal lobe to finally come back online. And the hard part is like, even if you didn't have trauma that was disrupting sleep by itself is going to take away your frontal lobe's ability to regulate your emotions. And so kind of it works both ways. Whenever you treat it, you're going to also improve indirectly the symptoms simply because the frontal lobe improves. And then there's a question of what else can help disrupting sleep other than good sleep habits. As far as, well, I'll say this is sleep disorders and sleep problems have to be treated, in my opinion, both biologically and psychologically. You can't do just one or the other. I just have never really seen that work. Now, on the psychological side, real quick, you can condition your brain to fall asleep anytime, anywhere, using the principles of behavioral theory, straight out of, I'm telling you, right out of classical conditioning and operant conditioning. That's the sleep hygiene part. When you hear people say sleep hygiene, that's what that means. It's literally healthy sleep habits. On the biological side, one, we've got to assess why this person's sleep circadian rhythm is disrupted. And if it is a disruption of that circadian rhythm, when did it start? And how can we help get it back to what a healthy rhythm would typically look like? The challenge is, and this is why I highly recommend that Brain Rules book, by the way, is there's a third of us that are night owls. And to put it bluntly, we ain't supposed to be working at 8 a.m. I say put it bluntly, to put it in my country terms. 8 a.m. is too early for us. And yet we're forced into a culture that requires us to kind of get, fall in line or fall out. And so there's going to be a higher predictability for at least a portion of the population, simply because we've got a rhythm to the day that doesn't match biology. I see your other questions there. And the only thing I would say is improving sleep is one, once you figure out where the circadian rhythm problems come from, and if it's an anxiety thing or if it is like a built-in biology thing, then we're going to tackle it from those angles. But in the end, in the short term, we need that person to sleep. And so I'm all about, I'm completely A-okay with the short-term and limited use of sleep medications, just to get that person to get some sleep, which then gives them the neurological capacity to start actually benefiting from the therapies. And if we do it right and plan it right, we can use that medication short term and then scale it back quickly before it learns that it needs that medication in order to sleep. And so when that's done with counseling, the medications, that tends to be the best approach. We also have to rule out things like sleep apnea, restless leg syndrome, REM behavior sleep disorders, the parasomnias, all that kind of stuff. And then another question was, what does normal sleep look like? That's like the perfect question from a grad student, by the way. That's like the grad student question. What's sleep? What does normal sleep look like? How often does a good sleeper wake up at night? Is it different if someone can fall back asleep? So most people wake up about 3 to 4 times every night and fall back asleep within just a few minutes. That's normal. 2, normal sleep consists of alternating patterns or cycles between deep sleep and REM sleep. And there are different stages of deep sleep. It's like 5 of them. You tend to, as you get older, you have less REM sleep and just less sleep overall. But you go from, as a teen who needs between probably 10 and 12 hours of sleep, sometimes even up to 14 hours. Same reason why toddlers need that much. To a young adult, to where about 8 hours is a decent number, give or take, plus or minus 1 hour. And that remains the same all the way through probably like the early 50s, at which point just a slow decline is noted in how much sleep you actually need on average. And you start to spend more time in deep sleep than you do in REM sleep as you age. And it makes sense because your brain's not needing to learn as much. You don't have to process new memories because you've done it a time or two. And it gives your body more physical rest because your body needs to be prioritized at that point too. And then another question was, You worry about do you worry about trazodone long-term use for sleep? I don't worry about trazodone biologically causing any kind of dependence or anything like that. But trazodone can psychologically cause pretty substantial dependence, meaning that we've probably all heard of like Ambien. So Ambien it's not supposed to, and it's, by the way, if you're taking any of these medications, don't stress out. Just hear it and just, talk to your doctor about stuff if you're concerned. But trazodone, unlike Ambien, is a hypnotic, meaning that it works primarily through the serotonin system and the histamine system too, by the way, which allows you, and it's supposed to allow you to fall asleep and stay asleep better. And the challenge is that because when something works, and it doesn't matter if you took a sugar pill, when you take something and you're like, oh, I had the best night's sleep ever, and I took a sugar pill, your brain is like, yep, and we're going to need it tonight too. That it learns very quickly what results in something that makes you feel better. And so trazodone physiologically doesn't cause any dependence because it's such a short acting kind of a phenomenon. And it's like your brain has many different things affecting the serotonin system at all times. But the psychological side of it can be challenging to not get stuck there. And if somebody's, worried about it making them feel sedated the next day, but they're like, well, I can't stop it though, because if I do, I won't be able to sleep. And that's going to be true, but from a psychological side, which is, to be honest with you, a lot easier to work with than the physiological side. Because things like Ambien cause a physiological response in the same way that alcohol would too, by the way, which in turn means that you're going to have both a psychological and a physiological dependence. And the physiological has to be titrated slowly and gradually in order for that to go away over time. Whereas trazodone, you don't necessarily have to do that from a physiological standpoint. Yeah. And I am going to have to wrap this up, folks. I know we went by quickly, and hopefully this was helpful to talk through trauma and PTSD. There's so much more that, I would love to spend hours and hours and hours in talking through, but we will plan on for sure for this coming Sunday. And if I can find the time, I'm not sure I will, but I'm going to try to find a time to offer for another optional in between class, just to give us a little bit more space. But I will for sure upload the recordings, and I'm going to make sure I've got access to those in the cloud. And then if you email me, if you have questions about the test or any of the quizzes, make sure you try to email me those in the next few days here, and especially if you get them to me by tomorrow morning, because I'll be right in the middle of answering all those questions, getting caught back up. So other than that, I hope you all have a wonderful night. Thanks for the questions. Those always help. And yeah, we'll see you guys next week.
Thank you so much.
Thank you.
Absolutely.
Thank you.
Y'all have a great night.
You too.